In previous lecture, we have discussed about pain perception and modulation. In today's lecture, we will discuss about management of pain. Person experiences pain only if the impulses passing through pain pathways reaches the higher centers. So in order to reduce the pain, we must prevent those impulses from reaching higher centers of central nervous system. So let's discuss the basic principles we can use to block these nociceptive impulses from reaching higher centers. First thing we can do is we can try to manage the source of pain. Like if there is wound, do something to promote healing and thereby to reduce the pain. Or if muscle spasm is the cause of pain, then try to reduce the spasm. Second principle is to block the pain transmission along the peripheral nerve. Then third principle is that in case if due to some reason we could not block the pain transmission at peripheral nerve, then try to block it in the spinal cord at the level of substantia gelatinosa, which is located in dorsal horn of spinal cord. This we can do by means of ascending pain suppression system, which we have already discussed in detail in previous lecture. Then fourth principle is that suppose if we failed to block the pain transmission at substantia gelatinosa in spinal cord and it progresses and reaches the brainstem, then we can use strategies to stimulate brainstem nuclei like periaqueductal gray matter PAG, nucleus raffimagnus and locus ceruleus, which in turn send their axons down to the spinal cord, where they can block the pain impulses at substantia gelatinosa by means of descending pain suppression system. This mechanism also we have discussed in detail in previous lecture. Then last, fifth principle is to block the pain transmission by means of central analgesia, which requires utilizing more higher cortical areas. Now with above principle in mind, let's come to treatment options which we have. So we will discuss them in order, that is from least aggressive to more aggressive options. Of course, it does not mean that for every case we will first try least aggressive option then proceed to more aggressive ones. No, it's not like that. Treatment plan, it will vary from patient to patient. Some patients needs to be treated very aggressively, for example intractable cancer pain, and for some patient a least aggressive treatment will be sufficient to manage the pain. And for some cases we need to utilize multiple options from least aggressive to most aggressive ones simultaneously. The treatment options in order from least aggressive to most aggressive ones, they include: first is physiotherapy management, next is medical management, and then last and most aggressive one is interventional procedures. So let's begin with physiotherapy management. So first principle is to manage the source of pain. In case of injury, we should use the modalities which can promote the healing. These modalities, they include therapeutic ultrasound, laser, then PLWS, also called as pulsatile lavage with suction, then maggot therapy, topical hyperbaric oxygen therapy, THBO, vacuum assisted wound closure, also called as VAC, then infrared radiation, etc. Here I have just summarized the most common modalities which can be used to promote healing. It is beyond the scope of this lecture to discuss the parameters of each and every modality or how to select the modality for particular wound or particular injury. For example, if we use the laser, we have to decide in which type of injury we will use infrared laser and in which case we will use red ruby laser, and whether to apply these lasers in continuous mode or pulse mode, and whether to use high pulse frequency or low pulse frequency, and how much energy density or treatment dose we will apply for each square centimeter area, which we measure as joules per square centimeter. This energy density in joules per square centimeters must be planned precisely according to the type of wound. If we apply higher dose, it in turn inhibits the wound healing, and if we apply the lower dose, it will not be effective. So the exact optimum dose is essential for proper and rapid wound healing. To discuss these things in detail, I need to make hours and hours of video, which is not possible right now. Maybe in future lectures, if possible, I will try to discuss these modalities in detail one by one. Now, next thing we can do is to reduce the pain. We can remove the substances which can stimulate or sensitize the free nerve endings. So how can we remove these substances? Most simple thing is to improve the blood circulation, which in turn drain these substances. There are various modalities which can improve the blood circulation, like shortwave diathermy SWD, long-wave diathermy LWD, microwave diathermy MWD, infrared radiation, therapeutic ultrasound, whirlpool, exercise, vibration, etc. etc. Here also I should remind that I am just summarizing the modalities, as discussing the selection of one particular modality from these or deciding their treatment parameters, indications and contraindications, it is beyond the scope of this lecture. The next thing is, imagine if the source of pain is nerve entrapment, then our aim should be to reduce the entrapment and thereby to reduce the pain. To do this, we can use mobilization, which may be joint mobilization or neural mobilization or tendal gliding. It depends on requirement or type of entrapment. Or we can use manipulation, which may be high velocity or low velocity. Then we can use traction or decompression therapy. The next most common cause of pain is spasm. In previous lecture, we have discussed about pain spasm pain cycle. So if spasm is the cause of pain, then our aim should be to reduce it. We can use various modalities to reduce the spasm. They include interferential therapy, transcutaneous electrical nerve stimulation, therapeutic ultrasound, thermotherapy, etc. This is all about managing the source of pain. Now let's come to second principle, which is to block the pain transmission along peripheral nerve. Here we must understand one important point, that different nerve fibers have different frequency range within which they can conduct the impulses. For example, C fibers, they can conduct impulses up to 15 impulses per second, and A delta fibers, they can conduct up to 40 impulses per second. And application of impulses beyond this frequency will lead to physiological conduction block. There are multiple modalities which can produce this required frequency and thereby cause physiological conduction block in these particular nerves. These include interferential therapy and burst TENS. There are different types of TENS, like acupuncture TENS, high TENS, low TENS, etc. etc. Again, this is beyond the scope of this lecture. Then next principle is to block the pain at substantia gelatinosa by means of ascending pain suppression system. To understand this, I strongly recommend you to watch and understand my previous lectures before continuing further. So, to utilize ascending pain suppression system, we must apply non-nociceptive stimuli via large diameter A alpha and A beta fibers. I repeat again, to utilize ascending pain suppression system, we must apply non-nociceptive stimuli via large diameter A alpha and A beta fibers. For this, we can apply vibration, joint mobilization, intermittent cervical traction, intermittent lumbar traction, high TENS, interferential therapy, whirlpool, intermittent compression, stretching, acupressure, etc. Then next principle is to block the pain transmission by utilizing brain stem nuclei like PAG, nucleus raphe and locus ceruleus, which in turn activate descending pain suppression system. For this, we must apply noxious and thermal stimuli, which passes through A delta and C fibers via spinothalamic tract. To achieve this, we can apply deep friction, cryotherapy, SWD, LWD, MWD, infrared radiation, acupuncture tense, low tense, IFT, wax therapy, contrast bath, hydrocollator packs, etc. Then last principle is to block pain transmission by means of central analgesia. Again, there are various techniques which can achieve this, like mental imagery technique, relaxation techniques, yoga, mirror therapy, cognitive behavioral therapy, biofeedback, hypnosis, etc. Again, explanation of each and every technique is beyond the scope of this lecture. So that was extremely brief explanation about physiotherapy management for pain. Now let's come to medical management. I have here very briefly summarized the medicines in order from most mildest form to very strong opiates. So most commonly used class of drug for pain management is para-aminophenols. These include acetaminophen, also called as paracetamol. This is the most commonly used OTC medicine for pain relief. It can be used for most of the pains, and most important adverse effect is liver toxicity. Next class is NSAIDs or non-steroidal anti-inflammatory drugs. These include ibuprofen, diclofenac, naproxen, etc. They can be used effectively for nociceptive or inflammatory type of pains. To understand the different types of pains, please watch my previous videos on pain. So we were discussing about NSAIDs. So the most important possible adverse effects of these drugs, they are gastrointestinal bleeding, nausea, and cardiac risk. Then next class is topical medications. They include capsaicin, lidocaine, NSAID, menthol, etc. They can be used effectively for nociceptive or peripheral neurogenic pain. And most common adverse effect is skin irritation. Then another class is antidepressants. They may be tricyclic antidepressants or serotonin and norepinephrine reuptake inhibitors, also called as SNRIs. Most common examples, they are amitriptyline, nortriptyline, and tramadol, which has SNRI effect. They can be used effectively for peripheral or central neurogenic pain and some type of nociceptive pains. They are especially important in chronic pain, as here the depression, it usually plays a very important role. And most possible adverse effects of these drugs, they are hypertension, orthostatic hypotension, arrhythmias, and falls in elderly, then dry mouth. They may cause constipation, blurry vision. There may be sedation, insomnia, or risk of serotonin syndrome, etc. Then next is the class of anticonvulsants. Here important examples, they are gabapentin, pregabalin, and carbamazepine, and they are effective for peripheral and central neurogenic pain. And their most common adverse effects include dizziness, fatigue, ataxia, peripheral edema, then dry mouth, Then there may be weight gain or weight loss, liver damage, etc. Then next class of medicine is muscle relaxants. In case of spasticity, the suitable drugs, they are baclofen, dantrolene and tizanidine. Whereas in case of musculoskeletal conditions, the suitable drugs, they are carisoprodol, chlorzoxazone, cyclobenzaprine, metaxalone, methocarbamol and orphanadrine. They are very effective for pain which is secondary to muscle spasm or due to trigger points, especially in case of fibromyalgia syndrome and myofascial pain syndrome. Their most common possible adverse effects, they are dizziness, drowsiness, fatigue, weakness, etc. Then next category is weak opiates. Here tramadol is the good example, and it can be used for peripheral or central neurogenic pain. Again, its common side effects include nausea, constipation, dizziness. Sometimes it causes vomiting, then it may cause pruritus, it may cause sexual dysfunction, sleep disturbance, then tolerance, addiction, risk of serotonin syndrome, etc. Then last category is strong opiates. They include codeine, hydrocodone, morphine, oxycodone, methadone, fentanyl patch, etc. These drugs, they can be used in very severe peripheral and central neurogenic pain and in cases of intractable cancer pain. Their common side effects include nausea, constipation, sedation, dizziness, there may be vomiting, pruritus, sexual dysfunction, sleep disturbance, tolerance, addiction, risk of serotonin syndrome, etc. So that's all about medical management. Now come to interventional procedures. So let's begin with nerve block. It is also called as local anesthetic nerve block. Here a combination of local anesthetics such as lidocaine is injected along with epinephrine, a steroid and an opiate. Epinephrine produces constriction of blood vessels, which in turn delays the diffusion of anesthetic agent. Steroids, they help to reduce the inflammation, whereas opioids, they are painkillers. This procedure, it can be used in many painful conditions, but most common ones, they are low back pain and complex regional pain syndromes. The next is joint block. Here the injection of anesthetic with or without steroids is given into facet or sacroiliac joints. It is effective in cases of facet or SI joint pain. Then coming to trigger point injection, here the Botox, also called as botulinum toxin A, these injections are given into trigger points, especially in myofascial pain syndromes. The next is epidural and intrathecal injections. Here the steroid injections with or without local anesthetics can be administered into epidural space or intrathecal space. This is also the most common route for administration of opioids. And this method is commonly used for neck pain, low back pain, radiculopathy, then post-herpetic neuralgia, and even to reduce the pain during childbirth. In the United States, over 50% of childbirths involve the use of epidural anesthesia. Then next is ablative techniques. These are relatively more aggressive techniques compared to those we have discussed till now. These include chemical denervation, cryoneurolysis, cryoablation, thermal intradiscal procedures, radiofrequency ablation, etc. And they can be considered in cases of neuropathic, facet or musculoskeletal pain. And they should be considered only if other less aggressive interventions have failed. Then next is implanted electrical stimulator. This can be used to provide subcutaneous peripheral nerve stimulation or spinal cord stimulation, and can be effectively used for many conditions like peripheral nerve injuries, neuropathic pain, then complex regional pain syndromes, also called as CRPS, then failed low back surgery. It can be used in phantom limb pain or cauda equina injury, and in cases of radiculopathy. It can also be used for peripheral vascular diseases, visceral pain, multiple sclerosis, etc. etc. Then another intervention is implantable drug delivery system. It can be used for infusion of medication into spinal cord or specific arteries which are serving the involved structures. Most commonly they are used for intrathecal drug delivery, which consists of a pump with a drug reservoir. Typically it is implanted in abdominal wall and it is connected to catheter which delivers medication into the intrathecal space. This can be considered for intractable cancer pain and can also be used for refractory spasticity, which may be due to cerebral or spinal cord injury. Or it can be also used in cases of intractable pain in other objective pathologies. And this is indicated in above condition only if the life expectancy of patient is at least 2 to 3 months. Then next is minimally invasive spinal procedures. These include vertebroplasty, kyphoplasty, percutaneous disc decompression, nucleoplasty, etc. Most common indications for these procedures, they are osteoporotic compression fracture and radiculopathy. So now let's end the topic of pain here. In next video, I will discuss about vestibular system. So keep watching. Thank you. Have a nice day.